Hello, good evening, everybody, and thanks for joining us tonight for the second edition of NLO Voices at the European Health Forum Gastein. As we did last year, thanks to the Gastein Forum organizers, the idea was to bring the voices of the most marginalized communities within the program of the European Health Forum Gastein. And the way we approach it was to have a session, a discussion, a conversation every night after the day, and bringing people representing some of these communities to discuss what were the topics discussed during the day and what they thought about it. And if you don't know Nobody Left Outside, it's actually an initiative that was launched here in Gastein in 2017, where we brought representatives of marginalized communities, including homeless people, prisoners, migrants, people who use drugs, LGBTQ and sex workers. And it was groundbreaking, and a lot of people who have been at the European Health Forum Gasteins over the years recognized that there was something that really happened, because it was actually the first time that we were bringing the voices of the people who had real significant challenges in access healthcare systems, despite having the full right to have access. And it goes from complex issues such as stigmatization, criminalization, to very simple ones, which how do you get into a hospital when you need your treatment, but you need to leave your dog at on the street because they won't allow your dog, and you live on the street, and your dog is really important, and you can't access treatment just because of that. So this is just an anecdote, but it illustrates some of the challenges of accessing healthcare that most of us are not really aware of. And so yesterday we had a couple of representatives from the NLO coalition, Freek Spinwijn from FENSA, representing the people living homeless, and Jules James from Sex Workers Europe. And tonight we have a panel where, as we did last year, we're mixing NLO representatives, members, the founders of actually the initiative, with the support of MSD. I'm Director of Public Policy for MSD, and we, from the work that we're doing with patient groups and civil society, we launched this idea and found NGOs who were interested, and in the end we built this program together. And we're always bringing somebody, a guest star, a star speaker from the day, so that we also integrate the discussion taking place at Gastein. So tonight we have Catherine GUINARD from the Wellcome Trust, LUCA Stevenson from Sex Workers, Roberto Perez GAYO from Correlation Network, an organization doing harm reduction program, and DENIS ONYANGO from the African Foundation representing the rights of migrants. So that being said, since we don't have a lot of time, and I want to allow everybody to have questions and a conversation, let's kick it off. And I think the first way to go about it, the simple way, is just what have you heard today, or even yesterday, because it's been a very full program, a great program this year, and maybe you share some thoughts quickly, or as long as you wish, bearing in mind the time. Let's start with Denis, please. Just speak and they will find your way.
Hello everyone, thank you for joining us this evening, and it's a pleasure to be here to be part of this conversation. Yeah, so I think for me it's really sessions probably yesterday, which was looking at healthcare financing, but also the economy of well-being, and also today we had something around health equity, which was my session. And I think central to all this is just the way, we look at healthcare systems and whether they are serving people appropriately. And of course, coming from the perspective of underserved populations, we are always, can I say, mourning, or can I say always complaining about something? But that's justified because we feel that our communities normally come as an afterthought. And for some of those issues, they are quite simple to fix. Earlier on, I gave an example. I mean, we saw from COVID that, there was a saying that as long as no one is we are only safe if everyone is safe. And you saw that with the vaccinations. You saw that coverage for vaccination was not limited to anyone. And there's a public health argument to ensure that everyone is treated. There's a human rights argument to ensure that everyone has better health care. And also morally, it's important that we include everyone. And today I gave an example of Europe with regards to migrants. We have two maps which are very contrasting. We don't have PowerPoints, but I'll show you one time, or one time you'll see them. There are two maps that show. One map shows countries in Europe that are providing screening for infectious diseases for migrants undocumented. And the second map shows those ones that are providing treatment, that are only providing treatment. And they are quite contrasting. And you find countries like Finland, Norway, in some instances, Austria and Germany, they provide some form of testing, but then there's restrictions on treatment. And so I would like to see a Europe, a healthcare system that is actually truly accessible. And that means that it is immoral, for example, for you to test somebody for HIV and deny them treatment. At the same time, it's immoral to provide partial treatment only for the condition of HIV, because we know that the communities we work with suffer from a lot of other issues, and health actually ranks very low in that list of priorities. So I think that we really need to have some serious conversations about some of these easy-to-fix issues, just removing those restrictions, trying to change those laws that bar people from accessing services, because it becomes expensive at the end. If you refuse to treat somebody, they come at a point of crisis, and that means that you are going to have to pay more. So some of these are common sense, arguments that we really can have. And let's put politics aside and just be public health professionals, determined to change health and make it better.
Please, Roberto.
Hello, everybody. My name is Roberto Perez. I work for GAYO in the European Human Rights Network. And how to choose one from all of the multiple topics that we have been addressing in here, especially because many are echoing. We could be jumping into the role of data, the extent to which actually there's evidence, which there is more than evidence of what we are bringing. I think it's like one of the things that for me was like an interesting element today that perhaps was not completely addressed explicitly, and there's something that you're bringing in there a tiny bit, is the relationship, or like the need to create a stronger link between human rights and health and policies in general. And like human rights is something that in general has been like very little mentioned in different ways that we could be working. Is like human rights as a way of like developing new indicators that actually are measuring the capacity by which actually health has having impact. Human rights as acknowledging the policies that are having damaging consequences into people. And then for me, at least through a perspective of like harm reduction, in which we are understanding that the harms we have to be dealing is not only health harms, but also like the harms that policy are having. This becomes very crucial, especially when we are looking it into this complex puzzle that we're dealing here between these global big discussions and at the same the very concrete ones of the individuals and communities that we work with. And I was just like thinking like, okay, what could be an example that we are dealing with in here? And then I guess it's always going to the basics, which is like is criminalization. And at a certain point I was speaking to like, yeah, that deals with all the transdisciplinarity that we are speaking in here. We are dealing with all this social conditioning of health outcomes, and all of this is doing into like also like the difficulties that we're having in producing knowledge about these communities. And if you go like simple example, drug criminalization, then suddenly there becomes this beautiful unpacking point in which you're seeing like drug criminalization related to actually marginalization and criminalization of particular communities, drug users, racialized communities, sex workers, and people experiencing homelessness. You see drug use as a, like criminalization as a big determinant of like lack of access into health and care. But even to the point that I was at some point thinking is like drug prohibition and war of drugs as actually quite of a big driver in climate change and deforestation. And there is like these moments in which still sometimes we are missing, tackling, and coming back to the idea of human rights, is like how the systems, the legal systems that we're having, actually they are having an important role. That's a bit of a starting point.
Thank you. Hello everyone, my name is LUCA Stevenson. I work with the European Sex Worker Rights Alliance, which represents 100 organizations in 30 countries, providing services to sex workers or led by sex workers. I don't know how you feel, but I can't even remember the beginning of the day. It was really like intense. I remember the last session and the session before that, so I can talk about this too. I think one thing that was really important for us is around like the social determinant of health. I think it's a thematic that keeps on coming, and for us it's critical. Like we know that the lives of sex workers and the marginalized communities are impacted by many social factors, in particular, poverty, housing, access to food, etc. And this is something that we need to keep looking and including in health policies. And I found like the last session on the global health, the EU global health strategy was like quite fascinating. I think it's quite exciting to see the process of consultation and what will be the outcome of the consultation and what will be the actual strategy. But a bit like Roberto was saying, I think what is still missing in the conversation is around human rights. And I feel sometimes in Europe we have this position where, especially some countries, like some Nordic countries or Western European countries, like set themselves as kind of, we are models for human rights. We are like respectful of citizens, we give rights. And actually it's really not true for many of our communities. So like if you look at sex workers, for example, in many countries in Europe, sex work is criminalized, whether it's sex workers, their clients, or what we call third parties. And that's the case in countries like Sweden, France, and Ireland, who not only criminalize the clients of sex workers, but also push globally for criminalization. And what I find interesting is that at the same time we are here, the France and other countries funding the global fund to end HIV, and at the same time pushing for policies that are directly impacting sex workers and other communities, direct access to health services. And if you look at HIV, for example, last year in 2021, I think 1.5 million people acquired HIV, and 650,000 people died of HIV-related illness. So it's still like a really huge, critical issue. But it's mainly impacting people from our communities. If you look at Asia, for example, 95% of cases of HIV were amongst young key population. 95% of young people who are men who have sex with men, trans people, sex workers, and people who use drugs. So it's really like a focused epidemic in our communities. And for us, there's really this emergency that we need to tackle the HIV crisis and many health crises of our communities, but you cannot do that if you keep pushing for criminalization of our communities. And there's a discussion, I think, that to be had, maybe here, maybe through NLO, maybe through other actors, about the role of policing in public health. Like there's a lot of conversation happening mostly around migration, racialized community, and the impact that criminalization and policing have on our communities. And I hope we can have more conversation about this. Thank you.
I've got one. You hold on to it. Thank you. So I'm kind of, I think kind of a reflection from today, and probably the kind of, as I'm kind of coming away from Gastein tomorrow, is I'm feeling quite hopeful. And I said at the last session on the global health strategy that I was speaking on.
Maybe just one thing. Can you tell us just, in a second, the Wellcome Trust and your role at the Wellcome Trust?
Yeah, sure. So Wellcome Trust is a global philanthropic foundation and funder of research with a focus on infectious disease, climate and health, and mental health. And the reason I was particularly interested initially just in participating in this panel, because it's not something that I pretend to be an expert in, but as a big global health player and a big global north powerful player with, funding at its disposition, we're really thinking about how we engage meaningfully with actors in the global south to really create a partnership whereby, we're developing, policy positions and advocating to governments in a way that truly represents the people that we're trying to reach. So we're at the beginning of a journey, and to go back to what I started to say, what I think's been interesting is that I think collectively there's a realization, and I think it's been sparked by COVID, that all of us need to work in a different sort of way. Global health needs to work in a different sort of way, that different sorts of people need a seat at the table. So with the global health strategy, my concern was that there would be the consultation in the normal way, and we were discussing this last night. My concern was that there'd be the consultation in the normal way, people from the Brussels bubble would respond, and then the EU would develop something. And what I found heartening is to learn that the EU has, that the Commission has gone out, travelled to different countries across the world and genuinely spoken to people about what they want, what they need, and that it feels like a kind of a brave new world of how global health is happening. And I think there's a genuine openness now to have a conversation with the Commission about how they get feed in the future to all policies and initiatives, not just the global health strategy, but this kind of antiquated way of kind of replying to consultations, which were really devised for people who have a master's in EU policy. That's not a fair, equitable, meaningful way of developing policy. And I think there's real appetite to kind of do things differently with the Commission. So I'm coming away thinking that there's kind of a mood to do things more ambitiously and just a bit differently. So I'm feeling good coming away from Gastein this year.
So bringing it, to the policy thing, and I hope this, short introduction helps you picture where NLO is fitting. But just, to help further, the Nobly Left Outside Coalition is not just a platform where we thought, for good reasons, that joining forces would make sense to be heard and recognized by policymakers, but also when you're joining the voices of different marginalized communities facing different situations, different features of discrimination, very quickly, and that was the breakthrough of 2017, we realized that the commonalities are so striking that a public health approach makes total sense. And so NLO, during the last 5 years, and it's our 5th anniversary, has developed a number of policy material. So this is not just advocacy and bringing the issue to the fore in public debate, but it's also informing policy making at the European level. And for example, NLO has produced, the members have produced a report for the WHO on the response from member states to the COVID-19 pandemic related to the situation of marginalized communities. And they actually sought out NLO for input, because suddenly they could actually have a single point of contact to get this input, which otherwise might be more difficult. Same thing with the European Commission. DG Santé, and specifically I want to mention John Ryan, was very helpful in making NLO a health thematic network for 2019, which also brought greater recognition to the issue. And my question to the panel now would be on this, policy-related efforts. The COVID-19 report for WHO Euro, the fact that now we're participating to a young health forum organized by WHO Euro in November, and all these ongoing very broad policy initiatives at the European level about non-communicable diseases, obviously preparedness and responsiveness to the next health crisis. Where do you think have we progressed? Is the issue of marginalized communities and access to health are finally recognized? Is it those broad initiatives tend to take for granted that they're covering everybody, but we've heard yesterday that in terms of data collection already, the NLO members and the different NGOs are sort of forgotten from so we don't really know, and so when we know, we can't measure. If we can't measure, we can't act. So please, DENIS, What are your thoughts about that? Or something else, if you feel stronger about something else.
So of course, you raised the issue of data. And what our earlier session, Anka Toma said we should not be waiting for the data to be complete before we start acting on it. We take the issue of data very seriously. We feel that both in the context of national health surveillance teams and researchers, there is very little appetite and very little interest in key populations and researching key populations, and we feel that we need to be able to have more research. I think that the data collection systems need to be more representative. When we're reviewing, as I was saying yesterday, when we're reviewing the COVID-19 response, most of the surveillance teams from different countries reported not having complete data. And earlier today I said that I also looked at the issue of data from an ECDC perspective, and they said that out of their register of 50 infectious diseases, they can only make sense of two, for migrants specifically, they can only make sense of two diseases, which is HIV and TB. And so the ECDC themselves have actually acknowledged this and say there's a lot that needs to be done by the national surveillance teams to be able to have more representative and more complete data. So that's really important. But I feel that we have moved forward as a collective, especially since we launched NLO. I think we've been part of a thematic network. We managed to write a letter to the Commission on HIV, hepatitis, TB. I think that we've published a health design checklist that gives guide to policymakers on how well the health systems have to be, and this is grounded on the WHO building blocks of health. But I think in that, the issue around medicines access and technology for me stands out. So I think that there are some policies around ensuring that patients get the best outcome, but also are able to access the latest technologies. I think is very important. So everything is important, but I think that we need to begin somewhere, and I feel that we are managing to make some headway in terms of raising these issues, in terms of getting platforms to raise these issues. But I think that in the policy-making process, of course, is not easy, and we hope that eventually we will have something that's really truly inclusive and that serves the needs of communities that we work with.
So, Denis mentioned the health service checklist. This is a very important document. It was actually the first document really that we produced with the NLO coalition, and it's a checklist. Basically, the coalition and the members felt that given all the commonalities and the challenges of health systems to really address the needs of populations that are easier to ignore or, so-called hard to reach, whereas, our starting point was to say, well, people are not hard to reach. It's more the health systems that are hard to reach for some people. So we reversed pretty much the thinking. So this checklist is really a to-do list for anybody providing health services wanting to lower the threshold and make sure that they design a health intervention specific for some populations that works. And so we still have work to do with this checklist. We could do better. But Roberto, you feel pretty strong. You were telling me last night that, yes.
Sorry. And if you're interested, you can take one home in a low corner in the foyer of Kursaal. So
yes, we have an NLO corner. So the checklist is available online and in paper. So the COVID-19 report, how does it, does it really address, is there something we can take from this briefing that you did for the WHO Euro? And could that inform, for example, today we heard about One Health. So what could the One Health agenda learn from just what we produced for WHO Euro?
Well, I'm really passionate about that particular report. I mean, not only because maybe as a bit of a context during the pandemic, COVID-19, WHO was coming and requesting for help for the NLO and all of the members of the NLO to provide evidence and to provide information about what is the impact within marginalized communities that this was having. And as a way of responding this, all of the communities gathered together to be really able to provide actually this information. And what this report has put forward is a series of points which I think like really strong. It's like, first of all, we continue having the discussion that there is a lack of evidence when actually it's like each of the organizations was able to provide information where it is like more sort of like formalized or less formalized. But many of the organizations that we are working in here, we are conducting monitoring and data collection actually activities that becomes the form and the base either of like official monitoring systems or more formalized like ECDC, EMCDDA, but also alternative providing different information. So already like that data and that evidence is in there in the systematic and a compiled way. At the same time, by doing it together, we were really able to develop a system that was able to provide a response to a long time concern, which is like we are able to pay attention to the specificity of the individual needs, circumstances of each of the communities, while at the same time be able to trace similarities among all, and then to be able to provide an advice that at the same time can be tackling all of the common points. And at the same time also like puts forward a tiny bit that when we're having this discussion about data, about communities, about evidence, is that it is sometimes not that much the extent to which there is an evidence, but the extent to which the conditions to make that knowledge accessible exist. Because oftentimes, like the information that all they are working is like is coming from the communities we're working with, is coming from the work that civil society is also doing and transforming and sharing and working around. So that opens another series of discussions when we are speaking about equity. That is the extent to which actually through this data and evidence relationships, sometimes we are establishing unequal relationships by which we are putting a very particular paradigm as the one that has to be doing, but all of the information that is contained within marginalized communities suddenly is considered as not sufficient, not evident, not complete, and that's the only source that exists, so to speak. And at the same time, that puts a bit of a different question when we are speaking about bringing the capacity to develop not only the knowledge, but also a methodology by which this knowledge can become actionable in policy making. That brings the idea that social determinant sometimes is not only about the specific legislations that we're doing, but also like the capacity that we're having of these communities to directly intervene in the transformation of these systems. Because at the end of the day, it's wonderful that many of our organizations are really able to produce evidence in data, but at the end of the day, if what many of the policy-making institutions are wanting is the data, but not the bodies of the communities that produce that data directly having a conversation, then we're having a problem as well, which is like you want the knowledge, but not the body and the actual direct representation. That's another level of inequity that in our case we were able to put forward.
And Luca, so I want to challenge you a bit.
Go for it, Boris.
I'm trying to come up with a smart question. That's going to be hard. So we have the checklist, but at the same time, there's a long history of interventions at the point, the point of care, the bus, the cars going into areas where sex workers are there and providing health care, health literacy, learning about their rights and so forth. So that's really at the ground level, and there's something like the checklist, but then there's the broad policies in order such as One Health. And how do you see how can we connect the dots?
Yeah, I think it's a big question even in our own organization as well, because we are asking for sex worker specialist services. Like we think that there should be services which are really made for sex workers, where sex workers can have access like to HIV treatment, but also mental health support in case of violence, for example, so kind of holistic support for sex workers. But at the same time, we also believe that sex workers should be able to access all health services without discrimination. And that's still very, very difficult. So I was recently doing a training with sex workers in Romania, and we're having a training about fighting for your rights, how to self-organize, access to health, etc. And then organically in the conversation, some sex workers started to talk about how they were treated in hospitals. And I feel often, or hospitals or health services in general. And I think what's interesting is that we often talk about discrimination, stigma, but these words are so vague. It's really like, we keep hearing them, and it's like, what is actually behind these words? And when I was talking to these sex workers, and you have to imagine it was a group of like around 30 sex workers. They were cisgender women, trans women, they were sex workers who used drugs, they were like male sex workers, many of them were Roma. So it's not just that they were sex workers, like most of them were living in poverty, and all these stigma were like intersecting. And we were telling us the stories about being discriminated in healthcare. It wasn't just that they had to wait a bit longer to be treated. It was stories of actual physical violence, of being refused to be treated, to be pushed away from the services because they were refused to be treated because they were sex workers or Roma or trans or people who use drugs. It's the really like physical exclusion from these health services. So in some way, we do want to have health services that are specific for sex workers, but we also want to have, which I think is also a recommendation in the checklist, training against stigma, training on discrimination and stigma for the health forces, for all health forces, for nurses, for doctors, etc. But I also want to make like a small point, because we keep talking about vulnerable or marginalized communities, and then we're talking about resilience as well. And I think these words are also like kind of thrown around a bit, and they actually carry a lot of meaning behind them. You know, if you think of like some sex workers, and like lots of the sex workers we work with, yes, they are marginalized, but they're actually not vulnerable. If you were telling some sex workers that we work with, oh, you are vulnerable, you already bring this kind of like looking down at these people, you know, like, I don't know how many of people in the room would be able to go in the street and work for 8 hours in this environment, make money to be able to send back to your family, to pay for like your mom to build a little house in Peru for like, think of a specific friend. You know, like the strength of sex workers is unbelievable. And I feel like often when we come from this like marginalized or vulnerable side, we actually already are putting people down. We already say like, oh, these people are vulnerable. We need to like somehow, you know, offer services that actually is not true. Like, you need to sit down with this person and talk to her and to us or to them, you know, from an equal perspective. It's like, how can we work together to create health services or the services that you need? Not me thinking that you're marginalized and vulnerable and I'm going to help you out. So, like lots of sex workers, they don't feel this way at all. And I think often we reproduce this kind of like stigma and vulnerability. Like, these people are extremely strong. Like, the strength you have to survive in the environment that many of our communities face is huge. Migrants to like cross borders, you know, cross half the world to go to a country. You know, yes, they are marginalized by the conditions we create. But, you know, we really have to think as well of like some of the concept behind these words.
Yeah, I'd love to come in on that, because I think something that I've been reflecting on over the last few days is just that point, really, kind of the language we use in global health is really important. I mean, the concepts behind them, but the language we use is really important. You know, we kind of, all of us use global north, global south, but those are global north concepts, right? So really being careful about, yeah, the language we use and how that does kind of continue reinforce power imbalances. So yeah, I think that's a really excellent point. Just wanted to pick up on that.
Well, thanks for this, because that was exactly my question. Because since, you know, there was this global health discussion, I was wondering, isn't there a typical blind side when Western countries with functioning healthcare systems talk about global health? They are really thinking about beyond the sea, and in fact, what I've been working for a long time on infectious disease, and 15-20 years ago, the German government Ulla Schmidt launched the Bremen Declaration, and they really wanted the industry, pharmaceutical companies having developed HIV products, to really go to Romania, Bulgaria, and Central Europe to see, okay, what can we do there? It's happening here also. Global health is happening here.
Yeah, I mean, I think it's really interesting, and again, that's a lesson that's been learned. So that's been learned, I think, since COVID. That, I mean, the EU kind of found a way of kind of bought loads of vaccines and then transported them to the global south, but then their health systems weren't sufficiently strong enough to actually get those vaccines into arms. And so you're like, what have we done? We bought these vaccines. There hadn't been sufficient engagement with some of the countries in Africa to understand that what was needed wasn't just delivering a bunch of vaccines. It went much deeper than that. There's other problems to face. So I think there is now a genuine, as I said, kind of like a better understanding that there needs to be meaningful engagement with, with the people you need to help. I hope that answers your question.
Oh yes, definitely. And so we have Dorothea Dalig, my colleague. Is there something on Slido? And really, I want to bring the views of or the questions from the audience. We have some very important people. I see one there, and don't hide. and so please, jump in.
Yeah, we have two questions actually from the Slido. And one is, I'm just going to read both, so you can pick what you want to answer. What can citizen communities do to make your voices heard?
To make it what?
Their
make
voices.
your voices heard. So what is the role of cities and communities? And one is, I'm just going to read the whole one. The LGBTQI community has gained a lot of respect and trust in Northern Europe in the last 10 years. How can we make sure to make progress amongst other countries as well? What needs to be done?
Which community? I didn't hear. Okay. Any thoughts?
I can always talk. So.
Go ahead.
No, I think about like citizen, like community, how to like support or increase the voices of like marginalized communities. I think that's the point of like every single person at their own level can do something. Whether you work, in a trade union, for example, like what is your position about sex workers? Like I'm going to talk about sex work in particular, but how do you include sex workers in your trade union? If you work for a university, is there any like discussions about it? What about students who sell sex? And sex workers are part of every community. Like there are student sex workers, there's single mother sex workers, migrant, trans, etc. So I feel like every part of civil society or every kind of like citizen can have a role in creating dialogue around the issues that we face. And I feel like what I was saying earlier about like the resilience or the strength of our communities, like at the individual level, lots of the marginalized people we're talking about actually have lots of strength, but so have our organization. Like there is national organization in every country in Europe and actually globally of organization led by sex workers. You have like, trade union of sex workers in Argentina with like 40,000 members. In India, they have organization with like 600,000 members, in like Kolkata, for example. It's huge. In comparison, in Europe, our organizations are much smaller, but they're still at every like national or regional level organization working with or led by sex workers. And this organization should be in dialogue with representative of the state, etc. And that's what I feel a bit at the European level as well. Like we exist for 15, 20 years. We have very, very, very limited contacts with most EU institutions. And the reason is not necessarily that there is bad, will. It's just like that we don't even exist in their radar. It's like why we should talk with like, the network of prostitutes. Like, how is that related to the work we're doing? It's like, actually, our work relates to gender equality, to violence, like, to trafficking, to health, to so many issues that you are working with. So I think it's very important to us that's like, you need to create dialogue, and dialogue start at the individual level and institutional.
Great, thanks. So we have a question here. Please introduce yourself.
Thanks, Boris. I was sitting in the margins of the room about marginalized communities, but since I was called on, but I actually have a concrete question. So my name is Ricardo Leite. I'm a member of parliament from Portugal, and I'm the founder and president of Unite, which is a parliamentarians network for global health, currently present in 85 countries, that aims to fill in the gap between recommendation from scientific and trusted organizations and getting policy done. Yesterday, you were mentioning the Portuguese example from my country of decriminalizing drug use, how that was so important to have so many consequences socially, among infectious diseases, within the drug users community, ending stigma in a way, or at least combating stigma. Of course, there's a long way to go from there, but these are first important steps. Working at this policy level, at a global level, where we try to identify opportunities for policy change, one of the things that we challenge with is because of these communities that tend to not be part of many reports sometimes, they're sometimes not part of the recommendations of policies that need to be changed. And so I would like to ask if NLO has considered doing like a list of major policy changes they would like to see at a country level. Like we know that some countries we have identified in terms of criminalization of certain social practices that shouldn't be criminalized and so forth, because those kind of tools for organizations that want to push for change and have that power to promote that change can be extremely useful. And of course, to share that we are willing to work as much as possible with organizations like yours. And you're right. Yeah, you do have the strength to fight, as do those that you represent. And so sometimes they're in more vulnerable situations, but sometimes they're much stronger than many of us. So thank you for your work.
Thanks. And another proof of something I believe strongly about is that, especially that I'm usually in the room, is that at Gashtan there's always more brain power than on the panel. Sorry, guys. It's just a number thing.
Thank you. Magda Rosenmüller, yes, business school, and the public can really contribute to the gender balance, no? That's maybe also one point. Great session, and really great that you organized this, and fantastic the work that you do. A question is that maybe something that you do already, but I thought now in the virtual age, where we can bring people from different countries, different experiences, and different ideas together, wouldn't it be interesting to do some, it could be capacity, it could be in parallel with capacity building, of bringing good experience together, and yeah, you might already do that, no? Across the North-South divide, and also from Africa. We did GIZ funded kind of a seminar for women empowered innovations in healthcare, and they loved it. We had women from Kenya, from Nigeria, from Burkina Faso, and they were just talking to each other while we also had a program that rounded up. Wouldn't that also empower people and give them to the feeling we're not alone? Like if we here in Nigeria, there's another group that does the same fight in Brazil or in Burkina Faso, and then also the learning of what works for us. Maybe it cannot be translated, but the idea might be able to be translated. So I would love to hear what is your experience in that. Thanks.
Great, thank you very much for the question. So, Denis, Roberto, I will ask you to answer the question from Ricardo about the action plan, capital A and capital P. Action plan. Yeah, we talked about it last night. The long list of things that need to change.
I'll quickly address this, also like acknowledging what is the limitations of like the work that at least I personally on my organization do that is within the European Union. Within the European Union and only like WHO Europe, this territory, like good practices exist. Good practices are shared. Good practices are documented. So that already is a mechanism that exists in place and is one of the tools that we are having. And then this is leading to specific changes. Like, for example, if we are looking into particular developments, if you look like, yes, on hepatitis C, then basically you have the latest guidelines that they are coming about actually how to achieve 2013 goals, and then suddenly you have like the moment that comes into like, cool, one of the things that we need to be putting forward is like to decentralize, and then need to be bringing into like the examples that exist within the community. So all these pieces exist in here. At this point, it's a matter of like how much knowledge and how much evidence, how many good more examples do we need to be producing and exchanging, or to what extent there is another sort of like conditions that we need to be tackling in order to actually this exchange to make it really upscale. Keeping in mind that, and coming back to many of the conversations we're having today, that on a local level and this small scale is already functioning in many different ways. And in many of our communities, it's already able to bring this capacity to take care for. It's not only about the resilience of our communities, but it's like the inventiveness, the resourcefulness, to be really able to deliver models of care that doesn't exist, but they are effective and they work. So it's more like what other conditions need to be there. The big action plan is too long.
So for the big action plan, we'll ask the big action man.
No, and anyway, there is no time. No, sorry. No, I just wanted to make one quick remark. Like, I agree, of course, with meaningful engagements with the communities themselves, with the people themselves. That's true. Like, we all agree on that. But I also would like to stress that there is a lot of professional expertise in the sector. In the sector that I represent, homeless sector, there is 10,000s of professionals in the sector. There is also academic expertise. And I get really frustrated at EU level that people seem to think it's enough to put people that have direct experience with homelessness around the table, even if the conversation is meaningful, and make abstraction of academic and professional expertise on these issues. And that exists as well and should be taken into account. There needs to be a space for that in the action plan as well.
All right. So with this, we come to the conclusion. Thanks a lot for joining us tonight. You're the bravest of the brave. And we'll see you later tonight at the 25th anniversary gala dinner, and expect some wild scenes. I've been there and it was not even the anniversary. So thanks a lot, and please visit nobodyleftoutside.eu, and you'll see there's a wealth of material and videos and podcasts and reports. Thanks a lot. Have a nice evening.